So thanks again for the invitation to come talk again about some of the newer data surrounding squamous cell lung cancer. I've decided to focus solely on first and second line therapies because this really is the most relevant in terms of the new phase 3 data that have come out, as Corey had mentioned, over the past couple of years. Let me try this. Yeah. There we go. So disclosures. So I'm going to break this down just very simply. We're going to start with a very brief introduction of what it is that I do in terms of sequencing treatments, just as an overview, which will then lead to a discussion about first-line treatment options and then second-line treatment options. Again, the idea is that we're going to pin to each one of these, look at the data surrounding some of the newer findings. So the first-line treatment, I think the question that I'm going to try to address is whether or not there is a best regimen, in quotation marks. And then for the second-line treatments, where there's been more movement, a specific look at each of the phase 3 studies, or some of the earlier studies taking a look at the newer treatments such as ramucirumab, the immune checkpoint inhibitors, and then finally afatinib. So this is one way to sequence things. And this is by no means the only way, but then again, there aren't very many ways to sequence things in squamous cell lung cancer at this point. So first-line therapy remains a platinum doublet of your choice based, as we'll see, on any number of given factors. I think the de facto standard for most patients now, you could argue, is going to be nivolumab or some immune checkpoint inhibitor, which would also be potentially Keytruda for the latter, pegged on PD-L1 IHC. And then this shifts chemotherapy plus ramucirumab to the third-line setting, and then a number of different options in the fourth-line setting and beyond, which I won't specifically get into, but we'll see a little bit at the end of this presentation. I think it's worthwhile to point out that at each of these lines of therapy, there should be a consideration for clinical trials, and there is an increasing amount of clinical trial work that's being done, both in terms of immunotherapy and then small molecule target inhibition. A lot of this is pegged to sequencing tumors, which I encourage everyone to try to do either at a larger center that does it, or through Foundation Medicine, or any number of other outlets like SWOG's LungMap study also. So again, in terms of first-line treatment for squamous cell lung cancer, is there a best? And for me, there really is no standard first-line regimen, no best regimen at this point. And part of this, or a large part of this, is because we just don't have randomized studies comparing every single one of these different possible combinations side by side. So a lot of the time, the selection is based on schedule, toxicity, subset analyses for existing trials on certain demographics or characteristics that might respond better to one versus the other, as well as, I think, familiarity, which plays always, I think, in oncology, some role in what we end up picking. I want to use the recent randomized phase 3 study of necitumumab as a way to contextualize a look at the first-line regimens. So the rationale for necitumumab in squamous cell lung cancer, and this was published earlier this year in Lancet Oncology, presented last year at ASCO, had not to do with the sensitizing EGFR mutations, but rather with a couple of other related phenomenon. One of them was EGFR amplification, which we know occurs in about 10% of squamous cell lung cancers. And as with adenocarcinomas, EGFR protein expression by IHC happens quite a bit. And in squamous cell lung cancers, the number of cases that have very high H scores is typically more common. This was the underlying rationale for studying cetuximab in the FLEX trial. And subset analyses in the FLEX trial, which I won't present now, did suggest there was an overall survival benefit, particularly in squamous histology over non-squamous histology, as well as something pegged to the H score. So the design was straightforward. It was a randomized first-line trial, cisplatin gemcitabine up to 6 cycles, or cisplatin gemcitabine plus necitumumab, again for up to 6 cycles. Patients on the experimental arm got maintenance necitumumab, and they took a look at EGFR protein expression by IHC as a pre-planned analysis also. And the data are shown here for the GEM-CIS, NESI, and then GEM-CIS. The median overall survival benefit was about 1.5 months, a hazard ratio of 0.84, which was significant. PFS benefit also numerically smaller, but the hazard ratio was 0.85 still, which was significant, and the response rate was not really numerically or significantly different. One of the interesting things that was presented at ASCO last year but did not find its way into the manuscript was the post-study therapy. And the one thing, again, back of the envelope calculations that I had done last year was everything was the same statistically. The only thing that was different from a univariate analysis standpoint was the proportion of patients who got docetaxel in the second-line setting or beyond, which was higher in the experimental arm, which may play into some of the observations that we found as a potential confounder, but hard to tease out, I think. So this is putting side by side many of the common platinum doublet regimens that we end up giving. Again, the cisgem-nesi data, and the cisgem data from the SQUIRE trial, and then carboplatin, carbotaxol, cisdosi, and the netoplasin dosi I just added. It was presented again and published at ASCO last year, but we won't get into that too much at this point. And if you look at the different numbers, response rates are relatively similar, more heterogeneity, but many of these are sort of centered around 30%. For median progression-free survival, all of them around 5.5 months. For median overall survival, all of these hovering around 10 to 11 months, and all of them are equally as toxic or well-tolerated, depending on what your perspective is in terms of grade 3 and 5 adverse events. So it's hard for me, at least, to take a look at these numbers and say really one jumps out as a winner. And so I think maybe the most optimistic standpoint is that this is a baby step forward. Which is not necessarily a bad thing, right? Baby steps are ways that we get to other places, but I think is sort of the realistic way that we have to see the necitumumab data at this point. Since the presentation at ASCO last year, the FDA's Drug Advisory Committee did review the SQUIRE data on July 9th. It was an interesting discussion that was available to take a look at in terms of what they thought. And I think the bottom line is that there was no yes or no vote. There was a lot of discussion about benefit and magnitude of benefit in the landscape of a disease that seemed to have essentially no new treatments over the past, I don't know how many years. And so, it'll be interesting to see exactly what ends up happening with that discussion. I think there are some limits to this, though, in terms of the regimen. One of them, again, is the modest improvements that we saw, though they were statistically significant. Of course, it's a cisplatin-based regimen, and so not everyone with this disease will be able to tolerate cisplatin for any number of reasons, which may limit adoption also. And the other thing is a little bit of an apples to oranges comparison. SQUIRE regimen did have necitumumab built in as a maintenance treatment, but the idea of maintenance chemotherapy in squamous cell lung cancer is immature right now. There have been looks at gemcitabine as maintenance therapy, we're looking at Abraxane as maintenance therapy, but none of these things have shown overall survival advantage. And so, again, a little bit of an apples and oranges comparison when you take a look at the regimens. But that's sort of how things stand right now for first-line therapy. So in terms of second-line therapy, I want to focus first on the ramucirumab data, the CYRAMZA data that was, again, published earlier this year. So the reason why bevacizumab is not approved for squamous cell lung cancer harkens back to 2004, David Johnson's initial publication and observation of the phase 2 trial of bevacizumab in non-small cell lung cancer post-carbotaxol, and they saw toxicity in terms of life-threatening hemoptysis, and these happened to coincide with patients who had squamous cell lung cancer. In 4 cases, there were anatomic features that would suggest that these were risk factors. But for safety reasons, of course, in the randomized phase 3 trial, squamous patients were excluded. And so since then, many of the trials for angiogenesis inhibition have shied away from squamous lung cancer patients, though a number of studies have demonstrated that there probably is not a safety signal once you remove these high-risk features from the patients who are enrolled. And in fact, the REVEL trial design did reset our expectations. It did enroll patients who had squamous cell lung cancer also as a second-line therapy. Prior Avastin was allowed. And they randomized patients to docetaxel versus docetaxel and ramucirumab, given once every 3 weeks. And all 3 endpoints were significantly improved: overall survival, PFS, and importantly, I think for me at least in terms of symptomatic patients, overall response rate. And if you took a look at the breakdown by subgroups, in this case I've highlighted the histology for overall survival, you can see that there was a trend towards improvement also favoring the ramucirumab combination, as well as for PFS for the squamous patients. A significant benefit to squamous patients was detected on subgroup analysis. So it is the first angiogenesis inhibitor approved for squamous lung cancer, approved in December of last year. It really is the new de facto chemo standard, at least in the second-line setting and beyond, because of that chemo standard I'll highlight. Some questions are, does this now reset what our chemo control arms are going to be in the future? At this point, it's a little bit unclear, but it makes sense that it probably will. And the other question is, it's tough. There aren't a lot of chemo drugs available for squamous cell lung cancer. And so if you happen to burn a taxane in the first-line setting, you're kind of up a creek in terms of the ability to use an angiogenesis inhibitor. So can we pair it with other chemo drugs like gemcitabine? Will it be safe? Will we be studying this in the future? These are all very good questions, I think. Practical questions also that we need to get some experience on. And then finally, as a segue to our next topic, does this precede or follow nivolumab or pembrolizumab? So as just a brief overview for the new kinds of targeted therapies in a way, targeting at least T-cell activation. This cartoon just shows a number of different activation and inhibition signals that are found on the T-cell receptor coupled to ligands that are expressed on a number of different cells, including cancer cells. And the one that we're focusing on, much of the research is focused on, is PD-L1 and PD-1. And of course, the FDA approved now 2 different immune checkpoint inhibitors. One in March of this year was the first for non-small cell lung cancer, specifically in squamous cell lung cancer based on one of the CheckMate studies. And then just most recently, the approval of pembrolizumab for patients who are PD-L1 IHC positive, also in October of this year for all non-small cell lung cancer patients. The Nivo data came out first. This was a second-line randomized trial against docetaxel. There was a companion trial in adenocarcinoma that was also positive. And again, just randomized nivolumab versus docetaxel. And the survival curves were great. We haven't seen survival curves like this in I don't know how long for squamous cell lung cancer. So the median survival 9.2 months versus 6 months, significant. You could fit your entire hand between the curves, not just a finger. And importantly, it was a trial unselected for PD-L1 expression. And on retrospective analysis of tumors that did have testing for PD-L1, there was no signal in terms of predictive power for high expressors versus low expressors. So for nivolumab, unselected by PD-L1 IHC is the idea for provision in the second-line setting and beyond. It's a little bit different for pembrolizumab, and these are data pulled from the New England Journal paper with Eddie Guerin as the first author. And this one, for me, is the most interesting figure, which was response breakdown by degree of PD-L1 IHC staining. So the way to read this is that the PS is not performance status, it's PD-L1 staining, and it ranges from 75 to 100%, 50 to 74%, et cetera. And the bottom line is that the response rates go up, as you can see in the orange, by degree of PD-L1 IHC positivity, such that by the time you get to very, very high expressions levels, you get an overall response rate of 45%, which is quite high. You can also see that it breaks down by PFS benefit and overall survival benefit. The black curve is PS staining greater than or equal to 50%, and you see the curves separate based on that, which is why the approval indication was pegged on IHC positivity. So again, greater than or equal to 50% seems like it's a magic number. Why would we not use this biomarker to select patients? And part of this, I think, is also found in the supplementary section for the paper, which is that your duration of benefit to immune checkpoint inhibition may not depend on the degree of expression. So this is the duration of benefit. The sample size is small, and hopefully there'll be an update later on, but basically it is the duration of benefit in a Kaplan-Meier plot based on the different PS cutoffs. And the median duration of benefit was more or less similar without any significant difference, which is important because this is not treatment that you give. You have a 2% chance of responding, and your response is going to be like 2 months, right? This is, even if you have a low chance of responding, the durability, if it's quite long, it's very attractive for everyone who's involved in this. And so this sort of colors some of the use, I think, of response data somewhat in terms of selection by biomarker. The other thing, as we know, and we're very familiar with now for this class of drug, typical resist, probably underreports efficacy. This is the nivolumab data that was in the Lancet paper earlier this year. These are spider plots, so duration of benefit, how long patients were on. These are all patients who had partial responses or better. And you can see that a lot of patients were on 48 weeks later on therapy, so very long responses. But on the spider plots for patients who had just stable disease, you also had a lot of patients who were having benefit in terms of the amount of shrinkage, even though it didn't meet PR criteria for quite some time, 36, 42, 48 weeks, 54 weeks also. So RESIST probably does underreport efficacy, which again goes into this notion that using this as the stratifier for response pegged to any biomarker may underreport efficacy. But anyway, the bottom line is that nivolumab really is better than second-line chemotherapy. Whether or not it's better than docetaxel and ramucirumab, we certainly don't know, but it is better tolerated. We know also one of the very interesting take-home points with the rate of grade 3 and greater adverse events was about a third compared to chemotherapy. When is a biomarker useful? It's useful when it clearly predicts benefit for one group of patients for one therapy over another. And so I think will have the most use in first-line therapy because the response rate, the progression-free survivals, these tend to be the longest. And so if you have a biomarker that shows that this thing is going to be better than first-line therapy, and certainly for pembrolizumab, for instance, PD-L1 IHC may do this for us, then it is a good way of selecting therapy. Less useful when this is not the case. And so even with low PD-L1 expression, we know that the response rate is about 8 to 10%, even for pembrolizumab. Again, in nivolumab, it's unselected for PD-L1 IHC. So it's less useful using this as a biomarker for selection versus standard chemotherapy. So the last thing I want to talk about is also the first thing I talked about, which is EGFR. And this is focusing on LUX-Lung8 now in particular. So the rationale for LUX-Lung8 was that earlier studies, particularly BR21 and the ISOL subset analysis, but particularly BR21, had shown that there was potentially some benefit to Tarceva in non-adenocarcinoma histologies, read squamous, and also irrespective of EGFR mutation status. We know subsequently that some of this is just misguided, some of this is wrong in terms of the benefit in a wild-type population. IPAS has shown this. Chemo is better than Tarceva in the first-line setting in wild-type patients. And then Satter and Delta and Taylor. And Delta and Taylor are the most recent studies and the ones that really address chemo versus Tarceva in a wild-type population, which is why I want to focus a little bit on some of these studies that were published over the past couple of years. So Delta and Taylor both randomized patients in the second-line setting to Tarceva or docetaxel. Delta looked at patients who were unselected for EGFR mutation status, but they then analyzed this after the fact and did a subgroup analysis based on mutation status. Taylor looked only at EGFR wild-type patients with non-small cell lung cancer, including squamous cell lung cancer patients, and randomized them to Tarceva and docetaxel. And in the wild-type populations, for the subset in Delta, the median survival was better significantly for docetaxel. And then in the Taylor trial, in all these patients were wild-type, again, there was a significant benefit for survival favoring docetaxel. If you took a look at the subset analyses also, these are the forest plots, I've highlighted in green the non-adenocarcinoma histology for Delta. You can see that the hazard ratio favors docetaxel clearly, significantly. And the Taylor trial, you see something similar, a trend towards improvement for survival in the squamous patients, as well as a trend towards improvement in progression-free survival in the squamous patients for Taylor. So if you put the data together, again, chemo is better than Tarceva, at least in the second-line setting, which sort of, again, gets at this notion that the benefit for Tarceva in an unselected population is probably small and smaller than single-agent chemotherapy. So this is the framework or the setting landscape for LUX-Lung8, which was a randomized trial of avatinib versus Tarceva in the second-line setting in squamous lung cancer patients. And it was a positive study. The median survival was improved by a month favoring afatinib. The median PFS was improved by 3 weeks favoring afatinib. The hazard ratios are all similar at 0.8. And the response rates were not significantly different, numerically a little bit better for afatinib. But the table 1, which is the clinical characteristics, are always interesting, I find, in studies like this for what they might be able to tell us might be going on. So if you take a look at table 1, there were never smokers in this study. As we know, for squamous cell lung cancer, being a never smoker is a little bit unusual. 7% in the afatinib arm, 5% in the Tarceva arm. And in terms of histology, it was not pure, all these patients were not pure squamous lung cancer patients. Some of these had mixed histology. Presumably, these were adenosquamous patients in 4%. And so, again, you might see where I'm going with this in terms of response rates that are in the low single digits, demographic information that suggests that there might be benefit in a subpopulation might certainly fall out in the analysis. And in fact, it did fall out in the analysis. If you take a look at, this is the forest plots for progression-free survival, I've highlighted just 2, histology and smoking history. And so if you look at histology, you can see that there was a better hazard ratio. It was not significantly different, but numerically better, which you can see based on the bar here, in the mixed squamous histology. And then in the smoking history, you saw an improvement in never smokers and light smokers over those who were current smokers. You could see a similar trend for overall survival. Again, a benefit that seemed to be better for mixed histology and a benefit that seemed to be better for never and light smokers. And so this kind of analysis should be familiar. It's the kind of analysis they did in BR21, the kind of analysis they did in ISIL for gefitinib and Tarceva back in the early 2000s. And so this is one of the concerns I have for the studies, that we saw response rates of about 6% for afatinib, 3% for alatinib in Lux-Lung 8. They took a look at EGFR sequencing. In about a third of these patients had enough material to do this, and they found the rate of positivity for sensitizing EGFR mutations was about 6% in each of the arms. So you put the numbers together, you sort of think, well, okay, maybe the 6% on average who had EGFR mutations, maybe these are the ones who actually responded, who had squamous cell lung cancer. And so the authors had concluded that the frequency, right, this is an important distinction, of EGFR mutations, because they were similar between the two arms, were unlikely to explain the differences in efficacy, which is true, but that sort of is not really the question of most interest, which is the elephant in the room question is, what is the predictive impact for EGFR mutations in this population, since the rate of positivity was about 6%. And that's something that has not yet been addressed, but I think something hopefully that will be addressed. And so this is the final slide. How do these measure up now, all of these second-line treatment options, afatinib, erlotinib, nivolumab, docetaxel, docetaxel-ram? And you can see that for the TKIs, the numbers are substantially worse than for any of the other options that we have available. So I think afatinib might have a role as a fourth-line therapy in terms of the hierarchy of things that are there. But I do think, and we have plenty of experience doing this now, that doing this genotype-phenotype correlation in this study is going to be important. It may ferret out exactly what that signal is, and ultimately this is what we found for Tarceva and gefitinib in lung adenocarcinoma. And that's it. Thank you.